Hello, everyone. I'm Deanne Wright, President and a member of the Board of Directors of the Scleroderma Research Foundation, America's leading nonprofit investor in scleroderma research aimed at finding new treatments and ultimately a cure for patients. Thank you very much for joining us for our 16th live webinar. Our webinar series is made possible by grants from Gilead Sciences and United Therapeutics. Today's session will run approximately 1 hour with 40 minutes on our featured topic, Emerging Therapies for Pulmonary Fibrosis and Their Relevance in Scleroderma. We will conclude with about 15 minutes of Q&A time. The phone lines have all been muted, so if you have a question, please use the chat box in the conference window. Please note that our webinars are for educational purposes only, and no information provided is to be considered personalized medical advice. Now it's my pleasure to introduce our special guest, Paul Wolters. Dr. Paul Wolters is a pulmonologist and Director of Biological Research for the Interstitial Lung Disease Program at the University of California, San Francisco. He specializes in the diagnosis and care of patients with interstitial lung disease and more specifically connective tissue disorders and their involvement in the lung. Dr. Wolters received his medical degree from the University of Minnesota, trained in internal medicine at the University of Colorado, and pulmonary and critical care medicine at UCSF, where he joined the staff in 1999. He is co-founder of the Interstitial Lung Disease Program at UCSF, as well as co-director of the Northern California Scleroderma Research Consortium, a collaboration funded by the SRF that brings together the rheumatology and pulmonology divisions at UCSF and Stanford. Dr. Wolters' own research is focused on understanding the molecular pathogenesis of fibrotic lung disease and using this knowledge to develop novel therapies for treatment. It's now my great pleasure to introduce him as he presents Emerging Therapies in Pulmonary Fibrosis, Their Relevance for Scleroderma Patients. Welcome, Dr. Paul Wolters.
Thank you, Deanne. It's a pleasure for me to speak to you all about these exciting new therapies that have been developed for treating pulmonary fibrosis. Although they've been developed in the context of treating idiopathic pulmonary fibrosis, I think they're really hopefully going to be a paradigm for treating interstitial lung diseases in general. So this slide is the outline of my talk, and what I'm going to do is just briefly review the classification of interstitial lung diseases broadly, both clinically and their pathologic classification. And I'm going to review for you why we think about these diseases in their different pathologic contexts, their relevance to scleroderma. And then in the second half of the talk, I'm going to review the 3 randomized trials that have been recently published for treating patients with idiopathic pulmonary fibrosis. And for each trial, I'm just briefly going to summarize my impressions of how those results may be relevant to patients with scleroderma and scleroderma-associated interstitial lung disease. So this slide broadly covers how we think about the clinical classification of patients with pulmonary fibrosis. And it's not meant to go over each of the different types of pulmonary fibrosis, but I just want to make the point that patients with pulmonary fibrosis can be separated into 4 broad categories. One category are patients who have lung fibrosis due to different types of environmental exposures, the classic one being asbestosis. Then there's idiopathic pulmonary fibrosis, which we're going to talk about mostly in this talk. The other broad group is patients with interstitial lung diseases due to autoimmune diseases. And then what we call the other category, which are sort of unique, different types of interstitial lung disease. But for today's talk, the 2 diseases of focus are idiopathic pulmonary fibrosis and interstitial lung disease associated with scleroderma. So just to remind you all, idiopathic pulmonary fibrosis is a disease of aging. Patients do not get this type of fibrosis before the age of 50. The disease tends to be progressive, and the average survival from diagnosis is 3 years. As you all probably know, patients with scleroderma are also at risk for getting an interstitial lung disease. About 70% of patients with scleroderma may have some form of an interstitial lung disease, and about half of the patients with scleroderma, that lung problem will be clinically relevant. So in the next slide, I have 4 pictures showing different pathologic classifications of interstitial lung disease. The one on the upper left is usual interstitial pneumonia, and it has a distinct pathologic appearance where the fibrosis tends to be subpleural. This pink stuff is at the edge of the lung is all scar tissue, and as you move into the center of the lung, you actually have normal lung. So it's a patchy disease. This is different from nonspecific interstitial pneumonia, where there is diffuse alveolar septal thickening, so all of the lung is abnormal, and all these blue dots are inflammatory cells. So this tends to be a more inflammatory type of pulmonary fibrosis. In the bottom left is a disease called desquamative interstitial pneumonia. This disease is characterized by fibrosis diffusely, but the hallmark is all these little bluish black dots are an accumulation of macrophages in the alveolar space. And on the bottom right is a different interstitial lung disease called organizing pneumonia. This is where the air spaces get filled with granulation tissue, this sort of loosely organized matrix that I'm highlighting here with the arrow. Again, the point isn't that you remember them, but you can see, I think, that they have distinct pathologic appearances. And the 2 of interest for this talk is usual interstitial pneumonia, because this is the pathologic hallmark of idiopathic pulmonary fibrosis. And the other one of interest is nonspecific interstitial pneumonia, or NSIP, which is the most common pathologic pattern seen in patients with scleroderma. Now, why do we spend our time trying to differentiate these diseases? The reason this matters is that depending on the pathologic pattern, a patient's prognosis is very different. So here is a survival curve of patients with different types of interstitial lung disease based on their pathologic pattern. And what you can see is that patients with usual interstitial pneumonia, or IPF, have the worst prognosis. The average survival for these patients, depending on the study, is 2.5 to 3 years. If you look at patients with a pathologic pattern of nonspecific interstitial pneumonia, or NSIP, you can see the survival is much better, and in this study the average survival was around 13 years. And desquamative interstitial pneumonia, that in this study, those patients had a very prolonged survival. So the diseases are different depending on their specific pathologic subtype. What's interesting is that we're learning that the pathologic subtype of UIP is not only seen in patients with idiopathic pulmonary fibrosis. It's required for the diagnosis of IPF, and it's seen in 100% of patients with IPF. But interestingly, we also see a UIP pattern in patients with different autoimmune diseases. So I'm showing here rheumatoid arthritis, and a UIP pattern is seen in 70% of patients with rheumatoid arthritis, and an NSIP pattern is seen in about 20% of patients with rheumatoid arthritis. In scleroderma, this is flipped, where patients with scleroderma and interstitial lung disease have an NSIP pattern about 75% of the time, and a UIP pattern about 25 to 35% of the time. So even though the clinical diagnosis of their interstitial lung disease is Scleroderma-associated interstitial lung disease, the pathologic subtype comes in two forms, either UIP or NSIP. Well, what happened? Okay, so this matters. This is relevant when you're looking at survival curves in patients with Scleroderma-associated interstitial lung disease. I showed you earlier survival curves for patients broadly with these pathologic patterns, and you see the similar difference in survival in patients with Scleroderma-associated interstitial lung disease. So this is a figure from a paper by Ari Fisher at Colorado, and he took a cohort of patients with Scleroderma-associated interstitial lung disease, and he looked at their survival depending on whether their pathologic pattern was usual interstitial pneumonia or nonspecific interstitial pneumonia. And just like the earlier survival curves that I showed you, patients with Scleroderma and a UIP pattern of disease have worse survival. It's about 3 years in this study, compared to those who have NSIP, where they have better survival. In this pattern, when you break it down to UIP or NSIP in different subtypes of clinical disease, this pattern always holds true, where patients with a UIP pattern do worse no matter the clinical context of their interstitial fibrosis. And this will be relevant later on when we're talking about the results of these clinical trials. And for us as clinicians, a major relevant unanswered question is UIP the same disease no matter what clinical context we find this pathologic pattern? Again, the classic disease where we find it is idiopathic pulmonary fibrosis, but we also find it in patients with rheumatoid arthritis or scleroderma. And again, when we find it in patients with these other clinical diseases, the disease tends to behave like IPF. So we're interested in learning, is this just IPF in a patient with rheumatoid arthritis or scleroderma, or is there some biological overlap between these diseases? So now I'm going to talk about the results of the clinical trials, and there's 3 important clinical trials that I'm going to review. These studies were all done in patients with idiopathic pulmonary fibrosis, in part for 2 reasons. One, we can clearly identify who these patients are, so we can get a uniform population of patients. And the second reason is that there are sufficient numbers of them that we can actually perform relevant clinical trials. So the first clinical trial was done by the IPF-NET. The IPF-NET was a group of researchers in the United States funded by the NIH to do clinical trials in patients with idiopathic pulmonary fibrosis. And the first study had the acronym of PANTHER, and the study was designed to compare placebo to patients treated with prednisone, azathioprine, and N-acetylcysteine, or N-acetylcysteine alone. And the rationale for this study is that at the time it was designed, this triple therapy was considered to be the standard of care for treating patients with IPF. Now, that standard of care was not based on large studies or of well-characterized patients, but this is what clinicians were using in their practice. And so that's the reason for the study. The study enrolled 341 patients, and it targeted patients with IPF and an FVC of greater than 50% and a diffusion capacity of greater than 30%. These are markers of more mild to moderate disease. It did not want to target patients with more advanced disease, so they were excluded. And there was 3 arms in the trial. There was the placebo arm. There were patients who received N-acetylcysteine plus prednisone and azathioprine. And then another arm where patients received N-acetylcysteine alone. You'll see the numbers are smaller in the triple therapy group, and as I'll show you in a second, that was because this arm was stopped early. The trial was designed to last for 60 weeks, and the primary endpoint was change in FVC. And this is the primary endpoint for all 3 studies that I'm going to show you today. And the reason FVC is used in these studies is that it's a very sensitive measure for the degree of pulmonary fibrosis that a patient has. And in numerous studies, it's been shown that the change in FVC correlates or predicts survival in a patient. So the greater loss of lung function, it reliably predicts a poorer prognosis. So it's a measure that we can get earlier as opposed to having to do survival studies. Nevertheless, there was secondary endpoints of death, acute exacerbations, or disease progression. So this slide shows the randomization. It worked pretty well. Again, there was 133 patients in the NAC alone arm, 77 in the prednisone azathioprine NAC arm, and 131 in the placebo arm. And you can see they're all pretty well matched. That for the age, the percentage of men, and in IPF, the disease is a little more predominant in men, so this is typical. You can see the measures of lung function, the 6-minute walk distance. This is a measure of functional activity in patients. So in this test, they're asked to walk for 6 minutes, and we just measure how far they can walk. And so this functional measure was pretty similar. And then there were 2 measures of patient-reported outcomes. One is the dyspnea, a measure of dyspnea, the UCSD shortness of breath questionnaire, and another one is a quality of life measure for patients with respiratory disease, the St. George Respiratory Questionnaire. And these measures were pretty well balanced between the 3 groups. So a well randomized trial. And here is the main endpoint for what we call Part A, which was placebo versus prednisone, azathioprine, and N-acetylcysteine. This arm was actually stopped early because of evidence of harm. As they were monitoring the study, it was noted that patients who received the triple therapy had more deaths or hospitalizations compared to the placebo group. This was a surprise to all of us who were involved in the trial. Again, this therapy was being used as the standard of therapy, and these data suggested that it was harmful to the patients. And so for that reason, that arm was stopped. The trial continued, nevertheless, and the placebo arm was continued, and we also continued the NAC alone arm and continued enrollment in the 60-week endpoint. And at the conclusion of that portion of the trial, it was found that there was no difference in the rate of FVC decline in patients who received N-acetylcysteine as monotherapy versus those who received placebo alone. Furthermore, there was no difference in the secondary endpoints of survival, acute worsening of their disease, disease progression, which is really change in FVC, the number of hospitalizations, shortness of breath, 6-minute walk distance, or their overall quality of life. So N-acetylcysteine did not modulate any of the clinical endpoints in patients with idiopathic pulmonary fibrosis. So what are the relevance of these results to patients with scleroderma? Well, this is there's uncertainty right now, but as I mentioned earlier, about 25 to 35% of patients with scleroderma and interstitial lung disease have a UIP pattern of interstitial lung disease. So what we don't know is whether immunosuppressants in patients with UIP in any context are potentially harmed by being treated with immunosuppressants. And so it's an open-ended question, and it's one that we're trying to sort through now because it's important. Scleroderma is believed to be a more immune-mediated interstitial lung disease, as opposed to IPF, where the disease is felt to be one of aging and telomere dysfunction within the lungs. So different pathogenesis, but in a subset of scleroderma patients, it looks just like IPF. So we need to sort out whether these diseases are pathologically similar, because if they are, treating them with the scleroderma patients with UIP, it may not be wise to be using immunosuppressants in those patients. So that's the conclusion of the first trial. I'm now going to go on to present the results of two other phase 3 trials that were published in May of this year. Both trials received a lot of press because we really think that these results are a major advance in treating patients with pulmonary fibrosis and especially IPF. The two drugs are Pirfenidone, and the second drug is Nintedanib. So I'm going to start by presenting the results of the Pirfenidone trial. So Pirfenidone, here's a picture of the chemical here on the right. This drug was first found to modulate pulmonary fibrosis in various animal models of lung fibrosis. The classic model of lung fibrosis in animals uses bleomycin to induce fibrosis, and Pirfenidone was found to slow progression of fibrosis in that animal model. The mechanism of action of the drug is a little uncertain. It's been shown to reduce production of TGF-beta in these animal models, and it attenuates the activation of MAP kinases in cells in culture. This compound has been studied in patients with IPF for about 15 years. I think the first phase 2 study using Pirfenidone was published in the late 1990s, and in that study there was a suggestion that it may slow progression of pulmonary fibrosis. There was then another phase 2 study published in the early 2000s. Again, the trend was towards protection of progression of pulmonary fibrosis. And so in around 2010, there were two phase 3 studies testing Pirfenidone in patients with idiopathic pulmonary fibrosis. The main endpoint in those two studies was change in FVC. And the results of the two phase 3 studies were mixed. In one study, the Pirfenidone-treated patients had slower progression in the loss of their FVC. In the second study, there was no difference in change in FVC. I should mention that the FDA requires 2 studies generally for approving a medication, and that's the reason that 2 studies were performed in tandem back in the early 2000s. So with those mixed results, the FDA in the United States did not approve Pirfenidone. However, the medication was approved for use in Europe, Canada, and in Japan based on a different study performed in Japan. But in the United States, the medication was not approved, and the FDA asked for another trial to confirm whether or not the medication actually slowed progression of IPF. And that was the background and basis for the ASCEND trial. And the acronym for the ASCEND trial was the Assessment of Pirfenidone to Confirm Efficacy and Safety in Idiopathic Pulmonary Fibrosis. As I mentioned, the 2 prior phase 3 trials had mixed results, and this was done in response to the FDA request. And the design of this study, they used the prior 2 phase 3 studies to design the ASCEND trial, and it was designed to enrich for subjects who would be more likely to have disease progression as measured by a change in FVC. The rationale being if you're enriching for patients who were more likely to progress, there would be more events and a better or a greater probability of detecting a signal in patients treated with the medication versus not on the medication. So here's the study design. As I mentioned, it was a highly select group of patients, of 555 patients with IPF. Interestingly, 1,500 patients, more than 1,500 patients were screened for the study, but only 555 were enrolled. They were randomized to either Pirfenidone or placebo and treated for 52 weeks. The primary endpoint was change in FVC, and the secondary endpoints are listed here, which some were categorical, such as a 50-meter decline in the 6-minute walk test, a 20-point increase in the UCSD dyspnea score, and then a combined endpoint of progression-free survival. And this was a combination of patients with a 10% or greater decline in FVC, a 50-meter or greater decline in 6-minute walk distance, or death. And then the final secondary endpoint was death alone by any cause, and that related to IPF. So again, here's the randomization, 555 patients, balanced numbers between those who received Pirfenidone and placebo, and then the endpoints. Here's the baseline, key baseline measures between the 2 groups. And the point here is to show that they were well matched for age, male gender, level of lung function as measured by FVC or diffusion capacity, a patient's ability to walk for 6 minutes and their distance, and their dyspnea score based on a UCSD, and then a definite UIP pattern on the high-resolution CT scan of the chest. So very well matched. And here's the results of the primary endpoint. This is change in FVC, and you can see that over the 52 weeks, the patients on placebo had a greater decline in their change in FVC compared to patients who received Pirfenidone. The relative difference at the end in the change in FVC was that there was a 45% protection or less loss of FVC in the patients who received pirfenidone. When you look at the data, and this is another way of looking at the data, and this was a categorical endpoint. So the patients who had a 10% or greater absolute decline in their FVC, and it was broken down by evaluated at 13 weeks, 26 weeks, 39 weeks, and 52 weeks. A 10% or greater decline, I believe, was used because in prior studies, when a patient has a 10% or greater decline in FVC, it's a very poor prognostic marker, and those patients tend to be at high risk for death. And when you look at this, what you see is that at every time point, there were more patients in the placebo group who had a 10% or greater absolute decline in FVC. So again, at 13 weeks it was separated, and this separation got greater at each time point. So again, favoring the medication. This slide shows the safety and tolerability of pirfenidone compared to placebo. Importantly, there was no difference in serious adverse events in patients on pirfenidone versus placebo. There were slightly more patients who had a more than 3 times increase in their LFTs in the pirfenidone arm. The main side effects with pirfenidone you can see here. Nausea occurred in about 36% of patients, rash in 28% of patients. Some other measures of say, upset stomach or dyspepsia were greater in the pirfenidone arm compared to placebo. But importantly, there was no significant difference in treatment discontinuation between pirfenidone and placebo. So even though there are these side effects or intolerances, the patients generally do not have to discontinue the medication due to these intolerances. And I'm not going to go over it, but there's ways of working through some of these intolerances by dose adjustment of the medication and other ways to work around it. So what is the relevance of this to scleroderma? Well, I think it's early days. There is only one publication of pirfenidone in scleroderma patients. I'm showing the key data from that publication here. This is a small case series of 5 patients with scleroderma-associated interstitial lung disease. 4 out of the 5 patients were treated with pirfenidone as first-line therapy. And you can see here on the bottom, this is change in FVC over time. So these are trends in 5 individual patients, and you can see their change in their FVC before therapy. In 4 out of the 5, the trend for the change in FVC was that it was declining. Then they started pirfenidone, and in, I would say, 3 out of the 4, there was a trend towards improvement. Over here, it's the absolute change in FVC in these patients from before therapy and 6 months before therapy until 6 months after therapy. And again, the FVC improved in these patients. Above these physiologic graphs is just a picture from one patient showing the chest CT scan at baseline, where you can see diffuse ground glass opacities in the patient's lungs. All these white haziness is what we call ground glass. It typically is associated with inflammation. And then 6 months after therapy, that white haziness has improved in this patient. So there seems to have been an improvement in this patient on pirfenidone therapy. I should mention this study was done, if I remember correctly, in Greece. So the reason it was able to be performed was it was done in Europe where the drug is approved. We don't really have any other data right now for pirfenidone in scleroderma patients. Interimune did do an open-label trial in scleroderma patients with the primary endpoint being safety and tolerability in those patients. I'm pretty sure that study is still ongoing. I'm also pretty sure that they were doing clinical measures in those patients, so it'll be interesting to see, at least in a case series format, if some of these moderately impressive improvements are seen in that trial, in that open label trial. So the next drug I want to talk about is Nintedanib. This is the third clinical trial in patients with IPF. The drug Nintedanib is an intracellular tyrosine kinase inhibitor. This drug has multiple targets. I listed the tyrosine kinases that it predominantly targets over here on the left, although it seems to have some activity against multiple other targets as well, multiple other tyrosine kinases as well. And when this drug was studied in a phase 2 trial, there was evidence that it slowed progression of loss of FVC in patients with IPF. And for this reason, the company, Boehringer Ingelheim, proceeded with phase 3 trials testing whether Nintedanib slows progression of IPF. As I mentioned earlier, the FDA requires 2 trials before they approve the drug. So 2 trials were performed. They were called INPULSIS 1 and 2. I couldn't identify an acronym for these. I think they just called INPULSIS 1 and 2. And these were 2 identical randomized controlled trials that were following up on the phase 2 results. The trials enrolled 1,066 patients with definite IPF or likely IPF. So to get into this trial, you didn't definitely have to have IPF, but you had to have very likely have IPF based on clinical features. Patients were randomized 3 to 2, so for every 3 patients who got Nintedanib, 2 got placebo. They were treated for 52 weeks. The primary endpoint was change in FVC over that time, and the secondary endpoints were time to acute exacerbation, any change in the quality of life, patient reported outcome using the St. George Respiratory Questionnaire. They looked at categorical change in FVC and death, both by any cause or respiratory deaths. And as I mentioned earlier, this is sort of some fine details, but in IPF, there is a certain radiographic pattern where you can definitely say that the patient has UIP on pathology. And the main radiographic finding is that the CT scan shows honeycombing. This trial allowed patients to be enrolled if they didn't have honeycombing on their CT scan, and they had the absence of other radiographic findings to suggest a different interstitial lung disease. And the 2 main radiographic findings would be ground glass or air trapping on the CT scan. So if they didn't have that, those patients were allowed to be enrolled in the trial. Here is the randomization of the patients for both INPULSIS 1 and 2. They randomized remarkably well. Again, you can see the average age. It's pretty similar between the 4 arms. The number of men was very similar. The level of lung function, similar. In this case, randomization was looked at with oxygen saturation and another measure of lung function. They were very similar. And the St. George Respiratory Questionnaire, a measure of other measures of quality of life in patients with lung disease, they were very similar. So the groups were well randomized. And here is the key study endpoint, both for INPULSIS 1 and INPULSIS 2, which was change in FVC. And you can see that for INPULSIS 1, in the placebo arm, patients had a loss of FVC of about 240 cc's over 52 weeks, and in the drug-treated arm, they only had a loss of FVC of 114 cc's. So the relative difference was 52%, and it was very similar for the amount of protection in INPULSIS 2. The relative difference in the change of FVC for the two groups was 45%. So really remarkably similar results in the two trials. Here is sort of showing that data over time scale, and really the point here is just to show that there was separation between the two arms even fairly early in the course of their disease. You can see the rate of change of FVC in the placebo arm, and by 12 weeks there was a significant separation between the drug-treated group and the placebo group. And similar to Pirfenidone, the separation was greater over time. Here is a summary slide of the secondary endpoints. One endpoint was the number of patients with IPF who were having an acute worsening of their disease, and there was no difference between the drug-treated arm or the placebo group. They looked at this because in the phase 2 study, there was a signal that patients who received Nintedanib had fewer acute exacerbations, but that did not hold up in the INPULSIS 1 trial. If you look at change in the St. George Respiratory Questionnaire, which is again a measure of dyspnea and other outcomes, the drug-treated group did better than the placebo group. And for pooling the two studies, for any death or respiratory death, the patients who received Nintedanib had better survival, or I should say a trend towards better survival compared to the placebo arms. This did not reach statistical significance. This is similar data on the bottom, but I just want to point out that in the INPULSIS 2 study, the patients who received Nintedanib had fewer numbers of acute exacerbations compared to the placebo arm. So a little inconsistent data between the two studies for the protection of acute exacerbations in the drug-treated group. And it's really uncertain why there was a discrepancy between the two studies. I think the only thing I can say is that it can be very hard clinically to definitely diagnose an acute exacerbation of IPF. So some of the uncertainty may be related to how challenging it can be to definitely diagnose an acute exacerbation. This slide reports the safety and tolerability of Nintedanib. There were no difference in serious adverse events between the two groups. Again, there was slightly more patients with an increase in LFTs. In the drug-treated arm, this disappeared if you stopped the medication, so it wasn't wasn't a key problem. The main side effect of Nintedanib is diarrhea. It was reported in up to 62% of patients who were on the therapy and nearly 20% of the patients who received placebo. And going along with loose stools or diarrhea, patients who received Nintedanib had more nausea as well. Importantly, there was no difference in treatment discontinuation between the two arms. So even though there was more diarrhea, patients were able to work through this side effect in general. So what does this mean for scleroderma patients? Well, unlike Pirfenidone, where there is a small case series, there currently is no data for the use of Nintedanib in patients with scleroderma. Although, as I outlined how the drug works, I mean, there may be some biological plausibility for testing this drug in scleroderma patients. So with these results, again, high-profile publications in the New England Journal in May, just last October, just a few weeks ago, both Pirfenidone and Nintedanib were approved by the FDA for use in treating patients with idiopathic pulmonary fibrosis. The commercial names for Pirfenidone is Esbriet, and for Nintedanib is Ofev. So these drugs are now available for patients with IPF. So a major advance for treating our patients. So to conclude, two new medications are now approved. Both medications slow progression of IPF. And if they were not compared head-to-head, but if you look at the data, the relative protection was very similar for the two medications. Both roughly slowed the loss of FVC by about half. Now, as I mentioned earlier, scleroderma-associated interstitial lung disease comes in two flavors. There's the NSIP pattern. I have these numbers backwards. I apologize. So NSIP occurs in 75% of patients, and UIP, which might be synonymous with IPF, occurs in 25% of patients. So questions for the future then is, for me, a major question is, should we differentiate between UIP and NSIP in scleroderma patients or other patients with autoimmune disease? Both because, as I mentioned earlier, patients with UIP tend to progress at a different rate than NSIP, and now we have medications that in one form you can think of as a treatment for UIP. I'm just putting that out there. The other key question is, are the novel antifibrotics Pirfenidone and Nintedanib useful for treating scleroderma-associated interstitial lung disease? We don't know that yet. It'd be great if they're studied in these patients. And if we study them in these patients, should we only study them in patients with UIP? I don't have answers to these questions. I'm putting them out there. And then the final thing is, could these medications be used for treating scleroderma-associated skin disease? Again, an unknown, but for me as a clinician for treating patients with lung fibrosis, it's a major advance because conceptually these two studies show that we can modulate fibrotic diseases, certainly fibrotic lung disease, and it provides hope, for me anyway, that we can modulate other fibrotic diseases in general, such as scleroderma-associated skin fibrosis. And with that, I'll stop and take any questions.
Thank you, Paul. That was really great and timely information. And given the challenges faced by patients with lung complications, this was really helpful. So we have about 10 minutes left, and we'll use that time to answer some of the questions that have come in. if you have a question, go ahead and type it into the chat box to the left of the main slideshow window.
And should I just start reading the questions, or?
Sure, that would be great.
So the first question is there a reason there were no females enrolled in these trials? That's a really good question. So the epidemiology of IPF pretty reliably shows that the disease occurs in 65 to 80%, or I should say the disease occurs predominantly in men. If you look at cohorts of patients, it's usually 60 to 80% men. So it wasn't that they were targeting men per se, it's just that men have the disease more commonly. The next question is, are there plans to test these drugs in scleroderma patients? Yeah, that's sort of what I highlighted in my conclusion. Again, I mentioned that Pirfenidone was studied in an open label trial, really looking at tolerability of the medication in scleroderma patients. I'm not aware at this time of any planned trials either comparing Nintedanib or Pirfenidone to currently available therapies or placebo-controlled trials. But it would be a great thing if that was pursued. Yeah, and then somebody picked up my error here. I thought you said earlier that 25% of scleroderma patients had UIP, but this shows 75%. That's correct. So 75% of patients with scleroderma have NSIP, and 25% it's UIP. And then somebody asked to define UIP and NSIP and tell which indicates rapid progression. So UIP is the pathologic pattern that predicts more rapid progression. And again, the interesting thing about that pattern is no matter what clinical context we see it in, the progression seems to be at about the same rate. And that observation is what really prompts the idea that it may be either biologically similar or possibly the same disease, just occurring in different clinical contexts. And we don't know if that's true, but I think it's a really important question to answer, especially in the context of these new therapies, which really targeted UIP patients.
Paul, we had a question in the beginning, just to maybe step back a bit, asking what an FVC is and maybe how that, why that's used.
So the FVC is the forced vital capacity, and it's a measure of lung function. So what happens is a patient takes a deep breath and blows out into a tube that can measure the total amount of air that they're able to expel from their lungs. And if a person's lungs are scarred, they can't expand them as well. And so it's a very sensitive measure of lung function and change in lung function. So it's reliable, sensitive, and it's used to sort of quantify fibrosis in patients.
Great. We also have a couple of people asking what methods are used to distinguish between UIP and NSIP. Someone asked about BAL, someone asked about CT scans, and then whether or not patients should be interested in knowing which form they have.
Yeah, so the best way to differentiate between UIP and NSIP is to have a surgical lung biopsy. In some instances, the CAT scan will have a classic pattern where we can say with confidence that it's UIP. But in scleroderma, it's a little more challenging to do that on a CAT scan. So should patients have a biopsy to differentiate that? I wouldn't be ready to recommend that yet until we know that these therapies, patients respond differently depending on the pathologic pattern. Does that make sense?
Yes, that's great.
It's something we struggle with nearly every week in our multidisciplinary conference where we discuss these issues. And I would say the consensus at those meetings right now is, not to get biopsies, but that we as researchers need to sort this out.
So one of the things that I noticed in the talk is that Scleroderma ILD patients seem to respond differently to immunosuppressive drugs than IFP patients. So can you talk a little bit about, and I'm sure you don't have data on this, but can you talk a little bit about whether that's a function of UIP or NSIP or just the overall autoimmune nature of the disease, and how do you think that could be sorted out?
Mm-hmm. So NSIP, as I showed earlier, is more of an inflammatory interstitial lung disease. And we think that that's why it tends to respond better to immunosuppressants. So if you use steroids or Cytoxan or Cellcept, patients tend to get better. Now in Scleroderma, if you take a whole population of people, predominantly they're going to have NSIP. And so if you treat that group with immunosuppressants, the whole group might get better. But if you look at individual patients, they don't all get better. And again, this is now the uncertainty part, which is what we want to know is, are the ones that didn't get better, is that the UIP patient? I would predict that it is, because patients with UIP, as I showed earlier, they don't do better, and if anything, they might even do worse with immunosuppressants. But that's mixing disease backgrounds and stuff a little bit, so I don't want to, I'm not, that's just a hypothesis right now that we need to sort out.
Right. It could provide great information for treatment, though.
Mm-hmm. Tailoring the treatments to the pathologic pattern as opposed to the clinical context.
Right. So in IPF patients, are there more obvious candidates for Pirfenidone or Nintedanib?
So there are some other compounds in trials right now. There's one that targets a protein called LOXL2, and then there's another one that targets integrins. Those are in phase 2 trials right now. Those trials were disrupted a little bit by these, exciting results. But my understanding is they're going to continue to be pursued because I don't want to be too negative here because this is a huge advance, but these compounds only slow progression. They don't stop it, so we don't have a cure yet, and they certainly don't improve lung function. So this is an advance, but we need to keep working to, make things advance further and really either stop progression, I think would be the next thing to strive for. So I think we're going to need other compounds.
Right. Are there ways that you stratify IPF patients to send them to one of these treatments or the other?
Not right now. They're equally efficacious. It's really by side effect profile at this time. Patients, the rash with Pirfenidone tends to be more associated with sun exposure. So if my patient goes outside a lot or works outside, it's probably not the best choice. And then Nintedanib, it's more loose stool diarrhea. So So again, if a person is a public speaker, it might not be the best medication for them. That's sort of how we're discussing them with patients right now.
Okay. And can you maybe just add a couple thoughts about, are there biomarkers that are emerging in IPF?
That's a great question. Yeah. So more and more when companies are developing new therapies, they're trying to, in tandem, have a molecular marker that their drug modulates so they can sort of test if the drug works. For these two drugs, there really isn't a biomarker right now for rates of progression or response to therapy. For scleroderma, I think it's really important to try and find biomarkers that would predict progression. I may have glossed over it at the beginning, but if 70% of patients with scleroderma, let's say, have interstitial lung disease, probably 20% of those, or 30%, it's not too bad. It doesn't progress. It's very mild involvement of their lungs. And what we don't know is who is it going to be more active in? It's a really important question to answer.
Right.
So the only marker we have is this UIP NSIP thing, because that would, if you have UIP, it predicts more rapid progression. But again, we're not recommending biopsies at this time.
Will any of the new vascular therapies that are coming online, like the endothelin receptor antagonists like Summit or macitentan, or the prostacyclin receptor antagonists, be useful in the scleroderma ILD patients?
That's a really good question. I would predict no, but I'm choking on my words as I say that because the endothelin receptor antagonists were tested in IPF, bosentan, macitentan, and they didn't slow progression of fibrosis. Now, again, NSIP is a little different disease. Would they work in that context? Maybe. But I think with the IPF result, the companies might be, reluctant to test it.
And the pulmonary hypertension can occur with both the UIP and NSIP. Is that correct?
Definitely.
Okay.
Definitely. Yeah. And it seems, in scleroderma, it's not it doesn't always correlate to the amount of fibrosis you have. In IPF, the more fibrosis, the more likely somebody is to have pulmonary hypertension.
Okay.
Methotrexate causing ILD. Somebody asked a question about that. Methotrexate can cause interstitial lung disease, but not the patterns that we were discussing here today. And it tends to be acute, and when the medication stopped, it typically goes away. So really is unrelated to the context of what we're talking here. And then somebody asked, would the studies be relevant for younger people? For example, a female of age 21. Not the current data that I showed, unless that person had a UIP pattern, but again, that's a little bit speculation, because it's very unusual to have UIP at that young age.
Okay. So we're just about out of time, and I'd like to thank Dr. Paul Wolters from UCSF and each of you for taking time out of your day to join us. In an effort to keep our webinars relevant and meaningful to the community, we ask for your feedback. So when you close the webinar window, please take a few minutes to complete our short survey and share your thoughts with us. Please know that we depend on your support to continue our investment in the most promising research as well. Visit us online at sclerodermaresearch.org or call our offices at 1-800-441-CURE to support our program. One quick note, our corporate partner, Apricus Biosciences, is excited to announce an upcoming clinical trial for scleroderma patients with Raynaud's phenomenon. If you are a patient or know a patient who's been diagnosed with Raynaud's secondary to scleroderma and you would like more information on this upcoming clinical trial, please email trials@apricusbio.com. Thanks again for sharing time with us today. And remember that this and all other webinars are available for free download on our website. Thank you very much, and goodbye for now.